All right, it is 12:01, so we'll get started. Hi, everyone. My name is Mary Robertson, and I am the director of the Indiana Cancer Consortium, and very excited to have a webinar launch of the Cancer Control Plan, which I can discuss it a little bit more with all of you. Just wanted to preface by saying we are recording today's webinar, so we will be able to have it and post it on our YouTube for those that weren't able to attend today. If you have any questions as we go along, please feel free to put it in the chat or save questions for the end, and feel free to come off mute. With that, I will also have Gage Van Dyne with the ICC covering some slides, and Taylor Isley with the Indiana Department of Health to also talk about some data that we've included in the plan. There we are. So here's the cover, as you guys have all seen. Again, as with all of our cancer control plans, it is a comprehensive roadmap for actions in our state to guide all of our efforts, from individuals to organizations and all stakeholders in between. It was developed by the ICC in support from IDOH and all of our wonderful members and other experts across the state. And I'll talk a little bit about the process more, but I just wanted to have a special thank you for those that were involved in this, because it definitely does take a village. Specifically, this plan, while all of our plans build on the last iteration, this plan does extend the 2018 to 2020 comprehensive plan, in that all of those strategies and objectives we are carrying over, and hope that all of our members and folks that utilize the plan are taking a look at all of those. But specifically, this plan hones in and augments 4 priority issues that the ICC has established for the state from our perspective, based on burden and data and research that we have seen. So in this plan, we have updated strategies specifically for colorectal cancer, breast cancer, HPV vaccinations, and tobacco use. Just reminding everyone that collaborating to conquer cancer, it's really the underlying theme of the ICC and how we utilize and strategize all of our efforts to go forward. It's a model that guides our efforts and our partners across the nation, and this is something that the National Comprehensive Cancer Coalitions use as well. So very excited that we now have over 400 members, including organizational and individual members, that we use to work together. And again, there's just the ICC mission that I like to push in front of everyone's faces as much as possible. So then we're going to take a look at specifically cancer in Indiana and some updates that we provided in this plan, and I'm going to hand it off to Taylor.
Great, thanks, Mary. I'm Taylor Isley, and I'm the cancer epidemiologist at the Indiana Department of Health. I'm just going to go over a little bit of the data that's in our cancer control plan. So working together, Indiana has made great strides over the past several decades in regards to our cancer burden. Although our state cancer rates have seen decreases, cancer is still the second leading cause of death. While cancer can occur at any age, middle age and older individuals are the most likely to receive a cancer diagnosis, with nearly 75% of our cancers in 2017 coming from individuals over the age of 55. The most commonly occurring cancers for both the state and the nation are the same. Excluding skin cancers, breast and lung cancers, which includes bronchus, are the most prevalent cancers among males and females respectively. Prostate among men and colorectal cancers among both sexes are the next most common cancers. But annually, lung cancer is responsible for the most cancer-related deaths among both sexes. Next slide, please. These questions help paint the picture of the true cancer picture in Indiana. In fact, at IDOH, these are the questions I get asked most often from the public. Nationally, men have nearly a 1 in 2 chance of developing cancer in their lifetime, while women have about a 1 in 3 chance. It has been estimated by the American Cancer Society that we expect an estimated 37,940 new cases of cancer in 2020, as well as 3,630 cancer deaths, not including certain skin cancers and in situ carcinomas. The costs of cancer have been rising in recent years, with approximately $183 billion spent in the U.S. on cancer-related healthcare in 2015. This is expected to increase by 34% by 2030. In 2017, Indiana's age-adjusted cancer incidence rate was 434.8 per 100,000 individuals. This is actually lower than the national rate of 438 per 100,000. However, although the current data shows that our incidence rate is below the national level, in Indiana, our mortality rate was 17.4% higher than the national level. In regards to Indiana's burden, our incidence and mortality rates have decreased from 2008 to 2017, with the overall cancer incidence rate in Indiana decreasing from 484.1 in 2008 to 434.8 per 100,000 people in 2017. The Indiana cancer mortality rate also has decreased from 194.4 in 2008 to 170.4 in 2017 per 100,000 individuals. With that being said, certain types of cancers do have different trends because this is the overall cancer trend. A significant cancer burden does still exist. While the cancer rate has gone down, the number of cases and the number of deaths of cancer are actually increasing. Continued and more target cancer control efforts are still needed, which is why we're so happy to have you guys with us today. An important question I often get is how we even track cancer in Indiana. The Indiana State Cancer Registry, which was established in 1987, compiles extensive information on cancer cases and other epidemiological cancer data. In addition to the Indiana State Cancer Registry, there are other sources of data that help us look at risk and behavioral factors, such as the Behavioral Risk Factor Surveillance Survey, also known as the BRFSS, that collects data on risk factors such as smoking, obesity, as well as screening rates among Indiana residents. Next slide, please. The National Cancer Institute defines cancer health disparities as adverse differences in cancer measures such as incidence, mortality, survivorship, the financial burden, screening, and the stage of diagnosis. Cancer disparities are also seen when outcomes are improving, but are not improving evenly across groups. Cancer disparities may be experienced by groups defined by race and ethnicity, disability, gender identity, income, sexual orientation, and other characteristics. Next slide. According to the BRFSS, in 2018, higher education and income levels correlated with a higher likelihood that women aged 21 to 65 obtain a Pap test within the past 3 years. Women aged 50 to 74 had a mammogram within the past 2 years, and adults aged 50 to 75 had a colorectal cancer screening that met with the United States Preventative Service Task Force recommendation. This shows that poverty is the largest contributor. According to the 2018 Indiana BRFSS, adults with healthcare coverage or a personal doctor/healthcare provider had significantly higher rates of cancer screening than adults without coverage or without a personal doctor. As you can see on that list, there are many other disparities that are well known in cancer, but now I'm going to turn it over to Mary.
Thanks, Taylor. Sorry about that. Jumped a little ahead. Excuse me. So now you have more information about the type of data information that we looked at. All of our experts that were involved in the process really examined, as we were thinking about this update, what areas we needed to focus on, and then strategies. So again, this builds on the last plan's framework and the goals covering primary prevention, prevent cancer from occurring, early detection, increasing those guideline-based screenings, treatment, promoting that shared decision-making, ensuring accessible and evidence-based care, and then also survivorship, improving the quality of life for those affected by cancer. Following that, we still have objectives that identify those key priorities that, when enacted, would make the most significant difference in our cancer burden in the state. As well as you can see in the purple box on the left, just like in the last plan, all of our strategies are divided into 4 key areas. Implementing policy, systems, and environmental changes, which I also may refer to PSE for short going forward, improving patient access to care, education, and programming, support provider training and professional development, and then also evaluate progress and outcomes. Again, the summary objectives, I won't read through all these, but I did just want to point out, again, we're continuing all of these over. So even though we aren't specifically addressing exposure to UV rays in this iteration, we do refer back to our past iteration, which still has great strategies that will tackle the exposure for UV rays along with all of these other objectives. And again, these are the rest of the objectives that are under treatment and survivorship, which you can see in the full plan. I wanted to touch on the influencers to conquer cancer, because a lot of times from the ICC and other states, we put out a cancer control plan and then kind of what happens. So I want to take a moment to reflect on it. It's just beyond individuals and individual movement. All of these key stakeholders that you can see on the screen have a role in carrying out reducing our cancer burden through all of our guided efforts. So you can find more clear definitions in our plan and the role that they play more specifically, but I just wanted to bring out, we hope from the organizational level that they're taking initiative as well. So then I'm going to go ahead and hand it over to Gage to talk about tobacco use, one of the specific areas we updated in this plan.
Hi everyone, my name is Gage Van Dyne, the Tobacco Prevention and Cessation Coordinator for the Indiana Cancer Consortium. So for the tobacco section of the ICCP 2021 to 22 update, the goal is to reduce the proportion of Indiana residents who use tobacco. This goal is carried over from the previous iteration of the plan and provides the framework for continued development of our strategies. Each area, not just tobacco, but the other three areas had committees formed to assist and guide in the development of the next iteration of this. Our tobacco committee members represent a number of organizations, and this is true to all of our areas, as we felt that it's important to bring together a diverse background of expertise and experience in the specific areas. In this iteration of the Indiana Cancer Control Plan, we've included narrative portions of each of the areas, specifically addressing the COVID-19 pandemic as well as health equity as they relate to the topical area. Our committees have worked diligently over the past several months to best tailor these sections to the current needs of Hoosiers. So despite the challenges presented by the pandemic, tobacco control remains a public health priority, and COVID-19, being a respiratory illness, now more than ever, shows that we need to bolster our tobacco cessation efforts. And part of our narrative addresses this issue. On health equity, within tobacco, there are many tobacco-related health disparities or differences that exist among various population groups, including tobacco use, access to resources, and things alike. The ICCP 2021 to 22 plan has identified priority areas in which Indiana's tobacco prevention and cessation address, listed there just under health equity on this slide. Next slide, please. Now, talking about our strategic actions, these are policies, programs, communications, interventions, activities that are categorized by cross-cutting themes. So in regards to our strategies, we aim to reduce the proportion of Indiana residents who use tobacco. Generally, all of these strategies carry over from the 2018 to 2020 iteration. However, some of them have been updated with language to better reflect our current climate, or some strategies were combined where it made sense and was just a little more concise in that nature. For example, in our last iteration of the plan, under the PSE area, we had strategies that talked about increasing the price on all tobacco products through a tax parity. We also had a point in which we discussed funding level for the state tobacco control program. In the current plan, we've combined and altered these strategies into a singular, more concise strategy reading, advocate for an increase on the price on all tobacco products through a tax parity act, and utilize funding to support the state tobacco control program. So that's just an example of how we've kind of updated the plan to reflect current language and really address issues for these next 2 years. Thank you.
Thank you, Gage. And then on to our next priority area, focusing on HPV vaccinations. So again, as Gage mentioned, all of ours address the impact of COVID-19 pandemic and health equity. And like most vaccinations, the HPV vaccination in our state, we are much lower than the national average. And at the beginning of the pandemic in 2020, we saw these numbers of uptake and series completion completely drop. However, because some vaccinations are required for school entry, for middle school entry, we did see an uptake in a lot of those others, such as Tdap. But because HPV is currently not required in our state, we haven't seen that return to previous rates as we saw in 19 for the usual uptake. So both impact of COVID-19 and health equity, the reason we focused on these so much is they are important to think about and what strategies we added to this plan and how we're going to carry those out and how we can do that in a realistic way and still make impact. And so with the vaccination rates, it's really important to consider using alternative methods for HPV vaccinations, such as looking at pharmacists or having specific doctor visits that are specifically just for vaccination. A lot of times the appropriate age is getting vaccinated because they are going for their wellness visit or physical at the beginning of the school year. So we have to think a little bit outside of the box there as well. Again, one of the other things we could do is really utilize the momentum around the COVID-19 vaccine and conversations about vaccines and how great they are for our community, and utilize that to really promote the uptake of the HPV vaccination as well. And then thinking about health equity as it applies, as you can see on the screen, a lot of the barriers for this specific issue can be grouped into access to care, financial concerns, and also the lack of medical trust or understanding. And so these are often entangled, and sometimes that does make it difficult to really tackle them with some strategies. But we can also see at the national level that within small cities and non-metropolitan areas is also an area that we can see the disparities that exist along with ethnic groups such as Native Americans. And then thinking about our healthcare facilities, our providers and such, financial concerns play a role there for those that are underinsured or uninsured for those out-of-pocket costs. But one of the most interesting factors I wanted to reiterate today was that actually the largest group that is most likely to refuse vaccinations due to lack of understanding or medical trust is actually for white middle to upper class families who make more than $75,000. So in all of those issues, one of the best ways we know to combat kind of all of them in one swing is for those school vaccination clinics. Again, with the last slide, this is a screenshot from a plan that has all of the strategies, but I did want to point out a few that I thought were specifically interesting in kind of the new times and waves. So under PSE, again, looking for those pharmacy-based opportunities, and again, continuing to use and achieve insure-based incentives for providers, because we know that's one of the largest impacting factors. So in order to get those completion rates up. Again, for providers, kind of looking at, supporting provider training and professional development, looking at those alternative providers again. So you can see educating oral health providers on how to communicate with parents and patients about HPV vaccination as part of that preventative measure for cancer at routine clinics. So that's an area that we aren't quite there yet, but it definitely is a new opportunity that could have a great impact. Again, collaborating and partnering with alternative groups to increase male vaccination rates, as we know that targeted messaging can have greater impact too as well. As in some people's eyes, HPV vaccination in some folks' eyes is still a female vaccination, which we know that to be not true. And then looking at evaluating progress and outcomes, looking at, again, that data transparency, providing vaccine report cards, or utilizing those national surveillance systems. Then taking a look at colorectal cancer. Both colorectal cancer and breast cancer, as we know, have seen huge impact in delayed and missed screenings, especially through 2020. According to the American Cancer Society, there was an estimated 90% drop in colonoscopies and biopsies just in the first couple months in March through April. In that sense, and this is nationwide, in that sense, there's also thought to be 8,000 missed or delayed diagnosis of colorectal cancer from mid-March through early June of 2020. And so we expect to have over 4,500 excess deaths from colorectal cancer over the next decade as well. So we're not only going to see the impacts immediately with that delayed screenings and treatment, but also later on. So it's really important that we take that into account as well. And then I'm going to go ahead and jump to health equity. As we know, African Americans definitely have a higher incidence in mortality when it comes to this disease, and they're also likely to be diagnosed younger and at later stages. So this is one of the reasons that the current screening recommendations from the United States Preventative Services Task Force is currently being reviewed. The American Cancer Society has already lowered their recommendations to 45 for average risk individuals. And of course, everyone should take into account their family history and medical history. And again, the objective we're addressing here is really across the continuum of care, considering primary prevention, early detection, treatment, and survivorship. Again, the screenshot from the plan with all of the strategies, and there were a lot of new ones in this plan, as we saw from the feedback that we got from our town halls and from our experts that served on this committee, where there was truly a need to be more innovative. And so one of those ways was to reduce barriers that were created by COVID-19, looking at financial costs, transportation, and utilizing telehealth platforms during both surveillance and survivorship are just a few examples. And then looking at increasing patient access to care, education, and programming, increasing awareness and accessibility of alternative testing, which a lot of folks are now looking at the opportunity to promote and educate on stool-based testing, that because of COVID-19, not everyone is comfortable going back to the doctor's office, or during different surges in different areas, they might not be able to accept patients at certain times. So what are the opportunity to get more people at average risk tested using that stool-based method? Again, not only thinking about early detection, but during COVID, really improving the quality of life for our cancer survivors, making sure the appropriate referrals are in place for all concerns, whether that's financial, physical, social, emotional, and covering all of those needs. And another interesting point that we specifically pointed out here was providing educational opportunities that do focus on minority populations that have a higher incidence and mortality rates. For example, African Americans and the LGBTQ population. Finally, taking a look at breast cancer, I won't reiterate the issues with delayed and missed screenings, seeing much as the high impact as we saw with colorectal cancer. But what was interesting about breast cancer, that some of the early research of the pandemic showed that not only screening diagnosis was delayed, but also treatment and follow-up. But on the downside or upside, there were some benefits that came out of that, with some more positive changes along with telehealth and coverage for that. Also some shorter hospital stays and staggering appointment times due to COVID. So we saw a little bit of shift. So it'll be interesting to see how it continues to develop as we continue to face the pandemic. Then taking a look at health equity, we can see large and clear differences nationally and in the state of Indiana. Specifically, mortality rates, late stage diagnosis and mortality rates have declined for US women, but it continues to have a substantial impact on Black women in our state. So they have slightly higher incidence rates, but they do have significantly higher mortality rates than white women. So this is important to remember as our strategies that we suggest on the next page, that we make sure to have these priority populations in mind for breast cancer and all of the other issues today, so that we're making sure we're tailoring those to really target the highest need. So some of the efforts and strategies you can see here, specifically tailoring some of these strategies for Black women who have the higher incidence in mortality. We can look at improving screening and treatment, adherence to Black women, specifically having those conversations of their risk and sharing the data and their personal history with them. Looking at timely and affordable diagnostic breast services, supporting funds for patient navigators to go through the process, and so on. Additionally, taking a look at some of the other strategies that we have here, under PSE changes in the first block, designing benefits worksite policies, payment plans, and reimbursement mechanisms to really facilitate the coverage for the evidence-based aspects of care and planning services. So these are just a few examples. I think a few other interesting ones that I would like to point out is, again, increasing that knowledge of the survivorship needs to the general community. You know, as some have that focus, once you beat cancer, you're okay. But survivorship is a whole another entity, a population that we definitely need to support and uplift from a variety of perspectives. And again, another great one to point out here, which goes beyond breast cancer as well, but collaborating with our awareness organizations to promote the existing resources of database throughout Indiana and increase the utilization of these resources for both patients, providers, care teams, and beyond. Again, we didn't point it out specifically in these slides, but again, all of these objectives are tied to metrics and measures that we have in our plan. And so you guys can individually take a look at that and see the progress. We have updated them from our baseline from before when the 2018 plan was put out until 2019 with the latest BRFS data that was updated. So. And I did want to take a moment to also point out the Cancer Control Plan dashboard. This is a screenshot right now. It still has our 2018 to 2020 plan structured, and it has the 2018 data, but it is currently being updated to reflect the new information, again, from the 2019 surveys that were available. It's a real-time interactive dashboard that provides a visual experience to see where we are in Indiana. As you can see, in that first primary prevention box, there is baseline 2017, 2018, and so on. So you can click around. It's a little bit more interactive and easy reference for folks when it comes to the data related to our state. So with that, that is all I have. And I just want to say thank you for joining us today. You can see all of our contact information there. Please feel free to reach out to any of us. And as well, put a plug for our Indiana Cancer Consortium annual meeting is going to be April 21st. So please mark your calendars, and this will be completely virtual and free as always. So please be on the lookout for more information and registration to come. And with that, if there are any questions, feel free to put them in the chat box or come off mute, and we would be happy to answer any of them. All right, well, I don't think we have any questions. Again, if any come up, feel free to email us. If you would like us to share this presentation or a shorter version with your organization, we would also be happy to do so. Please feel free to reach out. And with that, I thank everyone for joining, and have a great day.